Good evening, my dear friends and colleagues. Today we'll talk about another hereditary disorder affecting the kidney, which is tuberous sclerosis. This is our agenda. Tuberous sclerosis is an autosomal dominant disease considered as a tumor suppressor gene disease characterized by hamartomas. Hamartomas affecting multiple organs, especially kidneys, brain, heart, lung, and skin. But the most important organs are neurological, brain, skin, and kidney. So again, it's an autosomal dominant disease characterized by hamartomas affecting multiple organs. Now we'll talk about the etiology. Tuberous sclerosis results from mutations in two genes, in one of two genes, tuberous sclerosis 1 and tuberous sclerosis 2. Tuberous sclerosis 1 gene is present in chromosome 9, while tuberous sclerosis 2 gene is present in chromosome 16. This is very important. So, mutations are present in two genes. Tuberous sclerosis 1 in chromosome 9, tuberous sclerosis 2 gene is present in chromosome 16. And take notice of that chromosome 16, so it is very near to the BKD1 gene of the polycystic autosomal dominant polycystic kidney disease, and it can happen if there is a large deletions affecting both genes in chromosome 16. So we can have, in a minority of patients, we have both polycystic kidney and tuberous sclerosis. And these two genes are tumor suppressor gene. The function of the two genes, they are a tumor suppressor gene. So when there is mutation of these two genes, there is increased tumor formation because they are tumor suppressor gene. When there is mutations in them, so there will be increased risk of tumors and hamartomas will be formed. What about the epidemiology? Tuberous sclerosis usually affects 1 in 7,000 to 15,000 individuals, and we have noticed in our hospital increased number of tuberous sclerosis patients. About 70% of patients are sporadic with no family history. They result from new mutations. In sporadic cases, mutations of tuberous sclerosis 2 are 5 times more common than tuberous sclerosis 1 gene. So in sporadic cases, tuberous sclerosis 2 is much more common, while in familial cases, the ratio is 1 to 1, the ratio between tuberous sclerosis 1 and tuberous sclerosis 2. So in sporadic, tuberous sclerosis 2 is much more common, while in familial cases, the ratio is 1 to 1. Don't forget that tuberous sclerosis 1 is much milder disease. Tuberous sclerosis 2 is much more severe. What about the clinical manifestations? Patients, or if there is clinical features of both tuberous sclerosis 1 and tuberous sclerosis 2 gene mutations are very similar. But again, as we said before, tuberous sclerosis 2 gene mutations tend to be more severe. And the most common clinical manifestations, as I have said before, the most common is the neurological affection and skin, neurological, skin, and kidney. Neurological manifestations in the form of seizures, intellectual disability, and or autism. These are very, very important the neurological manifestations when we should suspect a child to have a tuberous sclerosis. Neurological manifestations include seizures, intellectual disability, and or autism. Skin lesions, we will talk about it in details now. You also, it might be affected by interstitial lung diseases and tumors of the brain, retina, kidney, and heart. The most common skin lesions, a very common presentations include facial angiofibromas, hypomelanotic macules is decreased pigment, hypomelanotic is decreased pigmentations, and unqual fibromas around the nails. The most common skin lesions, facial angiofibroma, hypomelanotic macules, and unqual fibromas. These pictures are very important for yourself in your clinical life and for the exam. Many times, it's a very common questions to and very common to be asked about tuberous sclerosis, and we can give a case scenario with a picture. Don't forget these pictures. This is facial angiofibroma, usually affecting the face, usually with a butterfly appearance. This is a periungual fibroma affecting the nails. This is what is called shagreen patch. It's an nevus, usually affecting the lower back. And this is what is called hypomelanotic macules, as we said before. It is called also ash leaf marks. Now we'll talk in details about the kidney affection in tuberous sclerosis. Kidney involvement in tuberous sclerosis. Kidney involvement occurs frequently in tuberous sclerosis, and the renal lesions, the common renal lesions include angiomyolipomas in around 85%, and these percentages are very common to be asked about. Angiomyolipoma in 85%, renal cysts around 30 to 40%, and renal cell carcinoma in 2 to 3%. Please don't forget these numbers. Angiomyolipoma in 85, renal cyst in around 30 to 40%, and renal cell carcinoma in 2 to 3%. Other renal affections might include focal segmental glomerulosclerosis, glomerular microhamartomas, and lymphangiomatous cysts, especially perirenal and peripelvic. Usually the kidney affections occurs gradually, but it has a considerable morbidity. Don't forget that. Especially when it is complicated by retroperitoneal hemorrhage and CKD and death. And this is a very common question. What is the most frequent cause of death in tuberous sclerosis? It is the renal complications. Renal complications are the most frequent cause of death in tuberous sclerosis. Now we'll talk in details about each kidney lesion, and we will start by the most common, which is the renal angiomyolipoma. Angiomyolipoma, from its name, it's a benign renal hamartomas. We said that the disease is characterized by hamartomas in many organs, so it is hamartomas in the kidney. From its name, it's a disease. Angio, so it is blood vessels. Myo, so it contains a variable amount of smooth muscle like cells, and adipose tissue. From its name, angiomyolipoma. It is the most common renal lesions in tuberous sclerosis, affecting, as we said, around 80 to 85%. By the age of 10 years, by the age of 10 years, Angiomyolipoma can occur in general population, but it is usually solitary. But in tuberous sclerosis, angiomyolipomas are multiple and bilateral. Multiple and bilateral, don't forget that. Also, an important note that the angiomyolipomas increase in frequency and size with age. With increasing age, it tends to increase in size and number. Can they become dangerous? Yes, they can become locally invasive, extending to the perirenal fat or the collecting cyst or vessels. Complications can occur secondary to hemorrhage, as we said before. It might lead to death. Hemorrhage might be retroperitoneal or mass effect causing tenderness and hypertension. Also, it is important to note that women tend to have larger and more numerous angiomyolipomas compared to men, and pregnancy usually increases the risk for rupture and hemorrhage. These notes are very important. What about renal cyst? We said that the second most common renal lesion in tuberous sclerosis is the presence of renal cysts. Renal cysts, also like angiomyolipoma, tend to increase in size and number over time, and the presence of cysts and angiomyolipoma is strongly suggestive of tuberous sclerosis. They are easily detected by CT. They can occur in any nephron segment. They are predominantly present in cortex. In some cases, they might be present in the glomeruli. The lining epithelium of the cysts have characteristic features with large and acidophilic epithelium containing large hyperchromatic nuclei with some mitotic figures. Papillary hyperplasia and adenomas are common. A small number of infants tend to have a severe form, the form of massive renal cysts, severe hypertension, and progressive decline in kidney function, with onset of end-stage renal disease in the second or third decade of life. This severe form increases the susceptibility that these patients have, as we said before, both gene mutations, because both of them are present in chromosome 16, the tuberous sclerosis 2 and BKD1 gene. So they have both polycystic kidney and tuberous sclerosis. Now we will talk about the third renal lesion in tuberous sclerosis, which is neoplasm. Benign tumors can occur, such as papillary adenomas and oncocytomas, can occur in tuberous sclerosis, but our main concern is malignant transformation or renal cell carcinomas. Patients with tuberous sclerosis have a 2 to 3% lifetime risk to develop renal cell carcinomas. Renal cell carcinomas that are present or associated with tuberous sclerosis have a unique clinical pathological features. These RCCs features include female predominance, younger age at diagnosis, association with angiomyolipomas. They are usually multiple and slow progression. These are the clinical pathological features of RCCs associated with tuberous sclerosis. There are three patterns for these three histopathological patterns for these renal cell carcinomas. The most common is the biliary, followed by the hybrid oncocytic chromophobe tumor, and the last one is the granular eosinophilic one. RCCs associated with tuberous sclerosis are usually having an indolent clinical course. They have an indolent clinical course. Now we'll talk about the diagnosis. There are criteria, major and minor criteria have been developed to guide our diagnosis. We will talk about it now. Imaging is the mainstay for diagnosis of the tuberous sclerosis associated renal lesions. The median age at presentation for both renal cyst and angiomyolipoma is 10 years. Most of the patients are diagnosed at this age. These are the criteria, the major criteria and minor criteria to diagnose tuberous sclerosis complex. What are the major criteria? Facial angiofibromas, angual or periungual fibromas, hypomelanotic macules, especially if more than 3, shagreen patch. As I said before, we saw the pictures for all these skin lesions. They are nevus. Also, the other major criteria include retinal hamartomas, subependymal nodule, subependymal giant cell astrocytoma, cardiac rhabdomyomas, and lymphangioliomyomatosis and renal angiomyolipomas. All of these are major criteria. What are the minor criteria? Dental bits, hamartomatous polyps in the GIT, bone cysts, gingival fibromas, and non-renal hamartomas. To diagnose a patient as having definite tuberous sclerosis, we need two major features, two major or one major and two minor for a definite tuberous sclerosis. What about probable tuberous sclerosis? One major feature and one minor to diagnose a probable tuberous sclerosis. While if only one major or two minor, it is a possible tuberous sclerosis. So again, to a definite tuberous sclerosis diagnosis, we need two major or one major and two minor. Again, renal imaging is advised for monitoring disease progression. This is very important. How to monitor our patients. We monitor our disease progression in these patients by renal imaging. Ultrasound historically has been the preferred modality, but it is insensitive to detect fat-poor lesions. What are the current recommendations for how to monitor disease progression? Current recommendations are to perform CT, abdominal CT or MRI every 1 to 3 years for life. Again, the current recommendations for how to monitor disease progression include abdominal CT or MRI every 1 to 3 years for life to assess angiomyolipoma progression and renal cystic disease. Sometimes the distinction between angiomyolipoma and renal cell carcinoma is very difficult, and sometimes biopsy is indicated. Why it is important to monitor a renal lesion or the renal affection? because, as we said before, kidney or the renal complications are usually the most common cause of death in tuberous sclerosis patients. Also to know that gene-based diagnosis is currently available. What about the treatment? We'll talk about each one of them. We will discuss first treatment of renal angiomyolipomas. Renal angiomyolipomas are generally benign and generally require no treatment in most of the cases. But larger angiomyolipomas frequently develop aneurysm with increased risk for serious hemorrhage, especially with aneurysms over 5 centimeters in diameter. In such cases, or in patients with large angiomyolipomas, preemptive treatment with nephron-sparing surgery or embolization might be needed. So in large angiomyolipoma, surgery or embolization might be needed. And if malignancy cannot be excluded, or renal cell carcinoma cannot be excluded, surgery such as enucleation or partial nephrectomy is preferred. Also, it is important to caution women with multiple angiomyolipoma about the potential risk of pregnancy and estrogen administration. As we said before, pregnancy tends to increase the risk of complications and hemorrhage. Recent international tuberous sclerosis guidelines recommend mTOR inhibitors as the first-line therapy for treatment of asymptomatic growing angiomyolipoma larger than 3 centimeters in diameter. So, mTOR inhibitors are recommended or considered as the first-line therapy for growing angiomyolipomas. Sirolimus and everolimus are effective in reducing angiomyolipoma volume and or post-embolization response rate. What about the renal cyst? The mainstay of treatment of renal cysts associated with tuberous sclerosis is strict blood pressure control. Surgical decompression has been suggested, but no significant beneficial effect has been established and usually not needed. What about the renal carcinoma or the renal cell carcinoma associated with tuberous sclerosis? Renal cell carcinoma should be suspected in, this is very important, should be suspected in enlarging fat-poor lesions. Take care of that fat-poor lesions, or when there is intratumoral calcifications are present. So what are the suspicion criteria? Enlarging in size, fat-poor lesions, or presence of calcifications. When these are present, biopsy is needed to exclude renal cell carcinoma. And RCCs, as we said before, in tuberous sclerosis are frequently bilateral, and renal sparing surgery should be performed whenever possible. What about renal replacement therapy in patients with tuberous sclerosis who reach end stage? End stage renal disease occurs only in 1% of patients with tuberous sclerosis. In every 100 patients with tuberous sclerosis, only one patient reaches end stage. It is more frequent in females. As we said, females tend to have a more severe disease with a mean age of 29 years. Both dialysis and transplantations are appropriate models in such patients, given the risk of renal hemorrhage related to angiomyolipoma and malignant transformation. It is advisable that patients with tuberous sclerosis who reach the end stage to have bilateral nephrectomy before initiation of renal replacement therapy because of these risk for these complications. So it is advisable for such patients to perform bilateral nephrectomy before initiation of renal replacement therapy. Thank you, and I hope you get benefit from the lecture. See you.